Good afternoon, everyone. I'm Nirav Shah, the director of the Maine CDC. I'm joined this afternoon by Commissioner Jean Lambert from Maine's Department of Health and Human Services. Commissioner Lambert and I are pleased to be with everyone this afternoon to discuss where we stand with respect to COVID-19 for the entire state of Maine for today, Wednesday, January 12th, 2022. Overall, across the state, Maine CDC has recorded 156,532 cases of COVID-19 and 1,623 deaths. Right now, across the state, there are 413 people who are in the hospital with COVID-19, a high mark in terms of total hospitalizations throughout the pandemic. For comparison, 2 weeks ago, there were 331 people who were in the hospital. Today, again, that number is 413. Of those, 106 are in an intensive care unit, which is down 3 people from 2 weeks ago. 307 of those individuals, however, are in non-ICU beds, which is the high mark throughout the pandemic. 57 are on a ventilator, which is 4 more people who are on a ventilator as compared to 2 weeks ago. These peak hospitalization rates are of obvious concern, both for the human toll they take, as well as the continued stress that they place on our healthcare systems. For all the discussion out there around Omicron being milder, it's important to ask, milder than what? And milder for whom? It certainly doesn't look milder when you consider the system as a whole. That's because even something that's milder on an individual basis can cause immense strain if it spreads more easily. That's what's happening with Omicron. Even if Omicron were, say, 10% milder than Delta, that's still 200% more contagious. The sum of that impact on our population is greater than its impact on any individual. Now, in terms of testing, there too, we have reached a high point. Our 7-day PCR positivity rate now stands at 19.76%. And it comes at a time when our PCR testing volume has also reached a high point. Right now, across the state, we are doing 825 PCR tests for every 100,000 people every single day. That is a high point for PCR tests that are reported to Maine CDC throughout the pandemic. Similarly, for antigen tests that are reported. Just yesterday, we hit a high mark there for antigen tests that are being conducted and reported across the state. Testing still remains a challenge, but it's also simultaneously occurring at record levels across the state. Now, in terms of vaccinations, Maine right now is administering 5,702 doses of COVID-19 vaccine every single day over the past week. That's an 18% increase just over the last 7 days and an 8% increase over the past 2 weeks. As a result of that hard work to get folks vaccinated, as of this morning, 76.5% of the entire population of the state is fully vaccinated. Now, I want to take a quick minute here to discuss and flag some recent changes to the vaccination dashboard that some eagle-eyed viewers may have seen in recent days. The most important thing to know about these changes is that at no time has anyone's vaccination data been lost, changed, altered, amended, or compromised in any way, period. The explanation behind this is tough to follow, but here's what matters. Staff at the Maine CDC spotted a problem early on last week. Our first priority was to ensure that none of the raw data was affected, and it was not. We then worked with our dashboard vendor, the vendor that creates the visualizations that you see, because that vendor was using an algorithm that wasn't properly drawing on the data, the underlying data, and projecting and visualizing it properly. We worked with them to spot the problem. We found the problem and reran all of the analysis on our data. That process is done now, and the numbers on the website have been updated to reflect that reanalysis. And finally, before I turn it over to our colleagues in the media for questions, I'd like to talk today about a change from the Maine CDC and the Maine Department of Education regarding schools and contact tracing. After receiving feedback from school leaders about challenges they are facing regarding contact tracing, I personally met with superintendents from across the state to learn more. Those discussions happened at the same time our epidemiology team was taking a hard look at our processes, particularly around contact tracing, in light of Omicron. Now, first, a quick reminder on what contact tracing is. Contact tracing is the process of working with an individual who has tested positive for COVID-19 to determine who they may have exposed, to identify what we all now know as a close contact. Those close contacts are then advised to quarantine. That entire process, in sum, is what we think of as contact tracing. Now, frankly, to hear that schools were experiencing challenges with contact tracing, well, it didn't surprise us. And that's because of the Omicron variant. There are distinct biological characteristics of the Omicron variant that reduce the effectiveness of contact tracing. What do I mean? Well, Omicron differs from prior variants in a few ways that are important to discuss as it relates to contact tracing. The first is that it is much more contagious, perhaps 3 times more contagious than the Delta variant, which itself was more contagious than prior variants. Second, it has a shorter period from when you are exposed to when you can begin infecting somebody else. That's called the latency period. Before Omicron, it was 3 to 4 days between when you were exposed to when you could start infecting somebody. With Omicron, it's shorter by about a day, not 3 to 4 days, but according to some studies, 2 to 3 days. And third, although not specific to Omicron, we now have a better sense that the majority of transmission happens in the days before symptoms and the first few days after symptoms. That is to say, COVID is a front-loaded virus from a transmission perspective, and Omicron even more so than prior variants. In short, trying to catch Omicron by contact tracing is like trying to catch a bullet train on a bicycle. The train is long gone from the station by the time you even get your helmet on. The train accelerates far too quickly, it reaches a much higher top speed, and it doesn't stop. Omicron-fueled COVID is that bullet train. Now, those factors explain in part why we're seeing record COVID cases. COVID's everywhere around us, in every county, every community, in every corner of our state. Those same Omicron factors at the same time reduce the effectiveness of contact tracing in schools. That's because contact tracing is based on the idea that you can identify a positive case, find their close contacts, and get them into quarantine before that close contact themselves becomes infected and spreads it to other people. It also presumes that you're covering all their bases of exposure, home, work, etc. With Omicron and its sky-high transmission rates, sky-high case rates, those assumptions don't hold. The biology of Omicron is such that contact tracing does not get to them fast enough. Omicron has changed the landscape, and we've got to change with it. And when it comes to contact tracing, we can't chase 2022's virus with 2019's methods. We make this change around contact tracing in recognition of the benefits of in-person education. Our goal last year and this year is to keep kids in the classroom. Being in the classroom matters. It's where kids learn. It's where many kids in Maine go for breakfast, lunch, and snacks. It's where they acquire the social and emotional skills that are critical for their own development. We recognize that being in the classroom is critical. That's why a critical piece of today's change is that only schools that have a universal masking requirement in place may safely suspend contact tracing. The masking piece is important because we want kids to be in school, but we want them to be in school safely. Masks help accomplish that. That's why when masking is worn universally, uniformly across schools for all students, faculty, staff members, and even visitors, we felt comfortable that a school could suspend contact tracing with that provision of masking in place. This is a pragmatic approach to keeping kids in the classroom and allowing them to be in that classroom safely. Now, this change comes as a surprise, and understandably, many parents out there will be worried about their child. What can you do to ensure that they stay safe as well as stay in school? Well, first and foremost, make sure that they're vaccinated, as well as boosted. Boosting as on top of vaccination are one of the most effective ways on an individual level to keep your kids safe. That's really what it comes down to. Being vaccinated and boosted means that even if exposed in school, your child's risk of contracting COVID is significantly lower than had she or he been unvaccinated. But it's not just your children, it's all of those around them. For example, is everyone in your household fully vaccinated and fully boosted? Is everyone else that your child comes into contact with taking similar precautions? There are other things that parents can do to ensure their kids' safety. They can make sure their kids are, for example, staying home if they're sick, so they're not exposing others. They can make sure that there's adequate filtration in the household and everywhere else your children go. All of these measures, in light of what we know about the transmission of Omicron, taken together, can keep kids in school as well as safe. So with that, I'm going to turn things over to our colleagues in the media. And the first question today goes to Chris Costa.
Hi, Dr. Shah, Commissioner Lambrou. I appreciate you guys taking our questions. If you don't mind, I apologize to ask what's sort of like a way back in the beginning of 2020 question, but I was not here when the pandemic started in Maine. I was working elsewhere. Can you just very quickly just make sure I understand the concept of hospitalizations? Are those just people who come into the hospital because they have tested positive for COVID? Or is it somebody who, because they come into the hospital, and then test positive for COVID, like somebody who has a heart attack or a car crash? Are those people also included in the hospitalization totals that are put out?
Sure. Yep, Chris, the hospitalization numbers that we report are those who are hospitalized with COVID-19. Of course, that includes some who are hospitalized for COVID-19. Some individual hospitals in Maine have also put out parallel data signifying how many of their inpatients are being cared for COVID. But our data are aggregate because our data recognize, among other things, that when it comes to the hospital and a hospital that's under stress and strain, it doesn't quite matter whether the patient who's coming in the door has COVID from a numbers perspective, because the impact on the hospital is equivalent in many respects. They have to treat the patient, whether they're there for COVID or with COVID, with the same degree of care to make sure that no one gets infected, no healthcare workers get affected, things of that nature.
Understood. So just to make sure, I wanted to follow up on that with sort of a different thought, but I wanted to make sure I understood that concept first. So obviously, as you said, a record number of people in the hospital with COVID, 413. It does seem, though, that we have kind of dropped down, as you mentioned, in terms of the numbers of people in the ICU, and ventilators have kind of stayed somewhat flat. Does that mean that in this surge that we're seeing right now, the severity of illness is less? And we're seeing people show up to the hospital with other things than just testing positive for COVID? I want to make sure I understand what's happening right now with our hospitals.
Sure thing, Chris. There are certainly folks who are coming into the hospital for other non-COVID related illnesses and who are testing positive. That's certainly happening. There's no question about that. Again, as I noted a moment ago, that changes the course that a hospital has to take from an infection control perspective, from a staffing perspective. If you're about to perform knee surgery on someone who tests positive for COVID, that may change the surgical plan, the anesthesia plan. So it still certainly has an impact. To your question, Chris, it's really too early to say whether the increase in non-ICU hospitalizations is a sign that Omicron is necessarily milder. It's definitely more contagious. There's no question about that, but it's too early to tell for sure to what extent it's milder. There are early data to suggest that on an individual level, it may be milder, but let's not glide over that. We're still talking about folks who are in the hospital. That is not something we should minimize.
Understood. And then my last question just is about something you also just mentioned, the importance of being vaccinated as well as boosted. I was looking at the data for the number of kids who are under the age of 5, data that the Maine CDC puts out about infections. It looks like the number of kids who have contracted COVID who are under that age of 5, meaning they cannot be vaccinated, has grown significantly from September to October, November, and December. The month of December, we had, I think it was 1,235 kids in that month alone who had tested positive for the virus. And I know that we have this kind of concept of Omicron possibly being milder, kids generally being less affected by COVID-19, but I wanted to get your input about this, the spread of the virus in these young kids who cannot get vaccinated. What's your take on this?
Yep. Chris, Maine is not alone in seeing an increase in number of children who are in that younger bracket being affected by Omicron or by COVID, much of that being fueled by Omicron. That's been a phenomenon that we've seen across the country. Thankfully, it continues to be the case, and you're correct, that children in general do not suffer the same degree of severe illness that adults can, although they can have long-term consequences, like conditions like MIS-C and things of that nature. It's again there too, Chris, too early to tell what the implication of this will be on kids. Our recommendation remains that one of the safest ways to keep younger children who can't yet be vaccinated safe is to make sure that everyone around them is fully vaccinated. Parents, friends, relatives, grandparents. That's the safest way to keep kids free from COVID.
Awesome. Thanks so much.
Yep. Thanks, Chris. Let me turn to Allegra from WABI next.
Hi, Dr. Shah. As people are starting the conversation about switching to those KN95 and N95 masks, I know that, we can order them on Amazon and get them sort of all over the place. How do you know that you're getting an authentic mask, and what should people be looking for if they do decide to make that switch and upgrade their masks?
Yeah. Thanks, Allegra. It's unfortunate that we're in a world where trying to ferret out whether the mask that you want to upgrade to is counterfeit or not is a question that folks have to grapple with. That's unfortunate, and I recognize how tough it can be, even helping some of my own family members navigate that. There are some resources that are out there. Namely, there have been groups that have sprung up to themselves make sure that they are selling true, correct manufacturer spec masks rather than taking a roll of the dice with something that you may find online. There are various different groups that have taken it upon themselves to make sure that the masks that they're selling have in fact been vetted and certified. And if it says it's made by 3M, it is in fact made by 3M. I've seen several of those out there. And that is one strategy. Now, of course, how do you know whether the group that you're relying upon is itself bona fide or a wolf in sheep's clothing? That's not easy either. So the other strategies are looking for masks in places that are known to sell reputable medical pieces of equipment, be it a pharmacy, be it a medical supply store, things of that nature. And finally, although I know there's a lot of enthusiasm right now around upgrading masks, good old-fashioned surgical masks, the ones that we've all come to know, remain effective. If folks want to upgrade beyond that, I understand where that instinct comes from, but good old-fashioned surgical masks remain a mainstay of a lot of the way that we can all protect ourselves.
Great, thank you.
Thanks. David from the BDN, over to you.
Great, thanks, Dr. Shah. My first question relates to the contact tracing change in schools today. Has data showed that most of the transmission occurring in schools is happening outside of the classroom? A lot of superintendents tell me that that appears to be the case. But do you think with Omicron that we could start seeing more cases that spring up within within school walls?
David, it's a risk, but that explains why I took a moment why we wanted to focus on masking. Yes, it is the case that schools may suspend contact tracing, but provided that they have a masking policy in place. And that really is credit to the value of masks. Indeed, our team reviewed much of the data, and there was one particular study that the US CDC published, conducted early on, about a year ago, finding that in schools where masking was the norm, transmission rates were significantly lower. And by the by, the masks that were used were not necessarily KN95s or N95s. They were more standard everyday face coverings. So David, could there be more transmission in the classroom? It's a possibility in light of Omicron's contagiousness, but the best way to mitigate that and keep kids in the classroom is by moving forward with masking.
Great. An Institute for Health Metrics and Evaluation estimate for Maine shows that right now around 375 beds are needed for COVID patients. They estimate using a variety of metrics that number will jump to 913 on February 13th. Obviously, that's an extremely high number. How much stock do you put into that estimate? And do you think a surge of that magnitude could be possible in Maine?
I've followed IHME's models throughout the very beginning of the pandemic. Like all models, they have their strengths and they have their limitations based on the various assumptions that they put in. In some cases, IHME's projections have been spot on. In other cases, they have been both understated and overstated, depending on the time and depending on the metric. So I view their analysis in the same way that we look at all models, which is to say, we look at all models. Models are not predictions of the future. They are planning tools to help us understand the upper and lower boundaries of what might happen. I can't say whether there will be that demand on hospitalizations. What I can tell you is that Commissioner Lambrew and I have had numerous conversations with hospitals, hospital leaders, clinical leaders across the state. That would be a challenge at that number, but we are working with hospitals every single day to make sure that to the extent that they've got needs that we can help fill, we're right there with them.
And it seems pretty clear that, even if hospitalizations don't go that high, if they were to increase significantly, there probably would be far more hospitals with crisis staffing, correct?
I think that's the case, yes.
Just one final question. About 1/3 of Maine children 5 to 11 are fully vaccinated. That number is much lower in some counties, especially in the rural parts of our state. Are you hopeful that number will increase? And do you think that having a vaccination number that low during this current surge could cause problems for transmission within that group?
Well, as you heard me note with Chris, yeah, we're certainly concerned about younger children. Chris was asking about the under 5, but to your point about the 5 to 11 or really the 5 to 19. As a group, the 5 to 19 school age kids are about half fully vaccinated. But as you noted, for 5 to 11, it's a bit lower, about 1/3. That's a concern. We'd like to see that number higher. That's one reason we've been working with providers to make vaccinations more accessible. As soon as boosters were available for a younger age group, we moved out with them at the Augusta Armory, as you recall from the discussion last week. So our goal here is to make vaccines as accessible as possible. They are one of the safest ways to allow kids to be in school, to be playing with their friends, things of that nature.
And it seems like there's kind of an emotional, level to the vaccines with children that isn't there with adults. But the number has gone up over time. I mean, do you expect that eventually, over time, these kind of emotional feelings about getting children vaccinated with the COVID vaccine could go away completely?
I can't predict what may happen on that front. All I can say, David, is as you noted, one of the things we've learned about vaccinations is that Someone, a parent, an individual who's not in favor of getting vaccinated on Monday might choose to do so on Tuesday because facts change. The reality of their life around them may change. People that they know getting affected by COVID may change. Friends of theirs whose kids get affected may change that mind. So we're not giving up. We want every single person to get vaccinated in the state who's eligible, and we're going to keep doing our part, educate, communicate, and provide the vaccines.
Thanks, Dr. Shah.
Thank you. Let me go to Amy Brown next.
Thanks, Dr. Shah. What percentage of the cases in Maine are Omicron currently? Has that been updated recently?
So, Amy, we look at, for a number of that nature, of course, there's not a magical sign on the wall that tells us exactly what that percentage is.
Right.
It changes, and we use a variety of different data sets to look at what the burden of Omicron is. Some of them are point estimates from different laboratories that are conducting tests across the state. Some of them are mathematical models. So we look at a lot of pieces of data to understand the Delta percentage, the Omicron percentage, and it changes day by day because Omicron is continuing to spread. Right now, our estimates are that Omicron accounts for anywhere from 77 to over 80%. One of the pieces of data that we look at are the genome sequencing, for example, that is done in partnership with the Jackson Laboratories. Those are the reports that we publish every week. Those data, however, are at least a week, if not further, looking back because of the nature of getting samples, sending them to JAX, putting them on their supercomputers. So that's one piece that we look at for the lower bound. And then we look at the point estimates to help us understand the higher bound.
Okay, so it's increased pretty rapidly to being the predominant strain in the state.
That is correct, Amy.
Yeah. With healthcare workers being allowed to go back to work while they're symptomatic in some places, and the US CDC relaxing some of their guidelines, letting people return to work sooner, how much public health risk is associated with those steps? I understand that they were made like with the healthcare providers so that there were healthcare, enough people working in the hospitals, but what is the balance of the risk of possibly being exposed to someone who's symptomatic, even though they're wearing a mask, versus having fewer people working that day? For instance, what's that math that goes through your head?
Commissioner, I'll let you start if you wish. Yep.
Sure. So the Maine CDC did adopt the US CDC guidance with regard to staffing. That guidance was to anticipate the strain on our healthcare facilities due to this rapid spread of Omicron. As a note, that this guidance really has levels of what to do when, and it really only advises that people use COVID positive staff as a last resort in a crisis. All that said, as a reminder, we're talking about healthcare facilities that must be functioning to help us tackle not just COVID-19, but all of our different severe health problems in the state of Maine. So we adopted this US CDC guidance to give our hospitals tools, if needed, to ensure that they have staff on their ICU units, to be able to make sure that their surgical units can operate to save people's lives. I also will note that our healthcare facilities have medical grade PPE. They have fit tested N95s. They wear all sorts of PPE when they're around COVID, around patients, let alone their colleagues. So they have an additional level set of mitigation tools in hospitals, in facilities that are not often available in different settings. So again, this is US CDC guidance. It's there with levels of contingency. This crisis use of COVID positive staff is a last resort. The circumstances for healthcare facilities like hospitals are different.
Okay, great. Thank you.
Thanks, Amy. Megan, over to you. Megan?
Dr. Shah, yep, sorry about the delay there. I just needed to pull up my screen. So just thinking about some of the things that you mentioned at the top of our call and Omicron as it relates to other variants, how it's different and how we need to be responding to it now. Are there any other guidelines that maybe, we went by at the beginning that wouldn't necessarily be effective against it now? I'm thinking specifically about, that 6 foot of distance, kind of guideline that we went by at the beginning. Does it even matter how far apart you are now? I mean, it seems like it's so contagious that you could be 8 feet, 10 feet. Does that 6 feet, is that now arbitrary?
So Megan, let me start by saying as you heard me mention at the top of the contact tracing piece in schools, our team is taking a look at all of the various things that we're doing to update them to be consistent with Omicron. The 6 feet piece has come under a lot of scrutiny even before Omicron, with some folks saying it should be wider, longer, and other folks saying 6 feet seems a bit much. The bottom line is that to the extent that there are questions around the 6 feet piece, Megan, they're not related to Omicron per se. The 6 feet piece comes from the fact that COVID travels through the air on droplets and aerosol particles. And that's how it spreads from person to person. It hitches a ride on those little aerosols and droplets when we speak or cough or sing. And that's how it goes from person to person. It exerts its more contagious effect once it gets inhaled by the body. So the 6 feet, for all of its strengths and limitations, is still in effect. That's not one that at least I have understood to be on the horizon for changes. There may be others, though.
Okay. And just quickly following up to, additional expanding testing sites. Cross insurance arena is open and, that's a really big one. But I remember last Wednesday, you kind of talked about efforting certain additional testing sites in other kind of more rural parts of the state. I didn't know if there was any progress on that, but I just wanted to check.
No announcements today, Megan. Just to note for folks, we are working to expand testing. On Monday, we went live with testing up here in Augusta at the Armory. Sites in Westbrook have expanded their offerings to build on what they were already offering. Megan, you noted in Portland, more offerings at Cross, et cetera. So we're working to expand testing specific to rural areas, Megan. We're continuing to work on that. Made some progress, but nothing to announce today.
Okay, thank you.
Thank you. Mel, let me turn to you next.
All right. Hey, thanks, Dr. Shah. I'd like to piggyback on that because I hear you talking about expanding testing and saying that we're at a high mark in terms of our testing volumes and things like that. But already in Portland at the Cross Insurance Arena, there are the only available appointments aren't until next Wednesday, and the Westbrook and Augusta sites are booked out until Monday. What do you say to Mainers who need a test now?
Well, the first thing is we acknowledge that testing is tough to come by. We're working to expand the offerings, at least for the sites that you mentioned, to see if they can do more appointments today, to see if the labs can accommodate more samples. So we've got more to do. We haven't stopped expanding and launching testing. We're hoping that there is more testing both in volume and in location coming soon. The other is that although PCR testing is important, it's not the only testing modality. I'd urge folks to cast a wide net if they need testing, both looking for PCR appointments, but also looking to see if rapid antigen tests are available. I say that freely acknowledging that they are tough to come by. I get that, although they are available from time to time online as well as in person.
No, we did speak to a woman who needed a negative test to be able to head back to work. And while she was able to fortunately get an appointment in Portland, she wanted some more of those at-home test kits to be available. And I know the state had an announcement about, purchasing about $250,000 from Abbott Labs. So what's being done to get those into the hands of Mainers soon?
Mm-hmm.
I think we are working aggressively on exactly that, trying to get those by next now testing, looking at alternative testing supplies. And again, those are tests for pharmacies, schools, and hospitals. They're not the over-the-counter tests. We do continue to look at what are our options to work to get that kind of over-the-counter test to Maine residents. We're hoping we have news on that soon. And I will just say we are hopeful that the Biden administration will be releasing some more tests for states. We've heard the rumors that there could be announcements in the coming days, so we look forward to that as well. Needless to say, as part of our daily work, how do we expand testing options? We try to put all of the available testing sites on our website. So for that person who's looking for a test today, do check out our website.
And then I do just have one last question. Since we are, some people at least are having some testing troubles, finding an appointment, finding those at-home tests, if the Biden administration's plan for employers to require vaccination or testing survives a legal challenge, how will Maine keep up with that added testing demand?
Yep, I can. Go ahead, Commissioner. Yep.
I would just say, we'll do what every other state's doing. We'll work with our federal partners. We'll work with the different manufacturers and expand our capacity even more. I will say, I think the current surge that we're having with Omicron and the, again, record high volume of testing is proof that when we have a need, we can figure out how to expand it. We will continue to expand it more. I will remind people that the OSHA rule would say to employers with 100 or more employees that if their workers are not vaccinated, then they must test weekly. So it's not testing for all their workers. It is for those workers who are not fully vaccinated.
Thank you.
Great. Thanks, Mel. Emily, let me go to you at the Sun Journal.
Hi, Dr. Shah. I'm wondering on the matter of PCR testing volume, does the CDC have information on any geographical differences? Is there a difference between, say, Cumberland County and Franklin County in terms of the volume of testing being conducted?
We do, or at least we have in the past broken it down by county, or I can check and see if one of our epidemiologists has that at the ready. I have not looked at those data in recent days, so I can't answer your question right now, Emily, but historically, we have seen differences in testing volume that's being done across the state, across different counties.
Okay, and then on hospitalizations, I'm wondering if there's a difference between, we've talked about vaccinated versus unvaccinated. Are we now seeing a difference in how people are faring, or the number of people coming in who are vaccinated and boosted versus vaccinated and not boosted?
We have not looked at the data around boosted yet in Maine, although I have been briefed on data that our colleagues in the UK and Israel have done to look at the difference between being fully vaccinated and getting hospitalized versus fully vaccinated and boosted and then getting hospitalized. And one of the compelling pieces of that data show that getting boosted reduces the likelihood of getting hospitalized even further from a point that it was already low after having been fully vaccinated. Getting your booster drives it even lower. Here in Maine, our numbers are thankfully on the lower end, which makes comparisons of that sort, boosted versus fully vaccinated. We just need to accrue more data before we can make meaningful comparisons of that sort. Just to underscore, though, Emily, what we have seen very consistently for weeks, months now, is that on average, in any given week, approximately 70% of people who are in the hospital in Maine with COVID-19 are not fully vaccinated. 70%. That's a quite staggering figure. In my mind, there are not many things in medicine or in public health that can reduce your risk by that significant degree, as can the COVID vaccines.
Do we have, for this week, I know the CDC has been collecting like a weekly census on vaccinated versus unvaccinated COVID patients. Do you have the most recent data? And do you also know the difference in critical care units and on ventilators?
What we ask hospitals to do to ensure that they have some time to look at the data and not be overburdened with reporting is just report into us on the aggregate. And usually those data are coming in today, analyzed tomorrow and reported out tomorrow morning, or analyzed tonight, reported out tomorrow morning. But for the past several weeks, if not months now, it's been pretty steadily about 70% of people in Maine hospitals with COVID not being fully vaccinated.
Got it. Okay. Last question. Yesterday, Governor Mills announced that the Maine National Guard, additional members will be deployed to healthcare facilities throughout the state. Is there any talk of deploying additional members to help out with testing?
I can start. Oh, sorry. Commissioner, please. Yep.
So at this point, we do have some National Guard that are helping out at the Augusta Armory testing. We are using that as a limited supply because we appreciate the fact that, as the governor stated when she called up the National Guard, she does that with great caution. It is a last resort, not a first resort, and we primarily are focusing the National Guard on hospitals for the reasons that we discussed. We really have to maintain the capacity of our hospitals to treat critical care patients. What we do is try to match the Guard into non-clinical jobs that frees up some clinician to be able to help a patient or helps decompress the hospital. Because going back to some of those projections, if we're anticipating more people with COVID-19 in hospitals, part of our solution is to move people out of hospitals who don't need to be there. So hospital decompression is a major part of the mission of the National Guard. We are trying to focus those resources on those types of activities.
Right. Okay. Thank you both.
Yep, thanks, Emily. Joe Lawler, over to you.
Yes. Hello. So my first question is just to try to get a better explanation of what happened with the data on the vaccine dashboard. We were told that it was reclassifying final doses to booster doses as the reason for the error. And then that seems to have reversed itself today. So is that not the explanation anymore? Can you explain that?
Yeah, that is what was happening, Joe. I'm gonna go through it really quickly, but it's the definition of weedy. But no, that is exactly what happened. I just wanted to give a quick overview at the top. So essentially, with the latest updates from the FDA and the US CDC expanding booster eligibility last week, there's an algorithm that reads raw data from our registry, and it reads that data and then generates the visualizations and percentages that you see. With that change, the algorithm that reads that underlying data began reclassifying final doses from the primary series of those who had not yet received the third dose and reclassifying them to the booster or additional dose category. So that's why we saw the declination of final doses and an increase in the booster dose category. The system was reading the data and assuming that only a third dose should be counted as a final dose, instead of reading the data as first dose, second/final dose plus booster. Joe, that is, I can't tell you the number of times I had to go over that with my team to make sure I understood it. It is pretty weedy, but that's what happened. We spotted it last week, as did, I'm sure, a lot of, again, eagle-eyed viewers. We started diving in with our vendor. We spotted the part of the algorithm that needed to be updated, got it updated, reprogrammed it, reevaluated all the data, and it is correct as of now. But just to underscore, the visualization sits on top of the raw data. The raw data in no way were affected, altered, amended, compromised, or changed at all. The raw data were intact. Where we had to fix was the visualization that draws upon those raw data.
Okay, got it. So it almost sounds like it was just a reverse of what we thought the problem was. In other words, instead of final doses being reclassified as boosters, incorrectly reclassified as boosters, it was boosters incorrectly classified and should have been final doses.
No. It was the first problem occurred first, and then we had to revert it. We can get you something a little bit more official, but yeah, it was props to the team for issue spotting that one and getting to the bottom of it.
Okay, all right. I don't want to take any more time on that. So another question I had is Boston. Is their wastewater data is showing already a decline in COVID cases, maybe suggesting the icicle phenomenon that you mentioned last week, and New York City is also showing this. And I know you don't predict, but is there a sense of how far behind we are on the curve in comparison? Like, did Omicron come to Maine later than Boston and New York? Do we know?
Yeah, Joe, you got me. You got to the punch before I did. I retired my crystal ball. However, we do rely upon when we're doing models and working with that, we look at what other states and regions have experienced and then use that to inform our experience. And it's kind of what we consider epidemiological time. And in epidemiological time, Maine is approximately a week, quote, behind. Again, in epidemiological time, the greater Boston area, about 10 to 12 days in epidemiological time behind New York, et cetera. So as you know, I cannot predict, and I'm familiar with that declination in wastewater PCR findings that came out last night. It was a little uplifting for me to read that last night. If it were to take hold here in Maine in similar fashion, we would expect to see the beginning of that impact, if it were to happen, in roughly a week.
Wow. Okay. And then my last question is just, you were talking about if the school districts would no longer have to do contact tracing if they had a mask mandate. Do you have a sense of what percentage of school districts right now do not have mask mandates? Is this a lot of school districts?
I am aware of the number, but I can't recall the exact figure. Maine DOE would have an exact number. Joe, we looked at those data, but I'd rather, unless I have it clear and crisp, I don't want to give anything incorrectly over the air. So the Maine Department of Education would have a better and more up-to-date sense. Let me go to Catherine from the Maine Wire next.
Good afternoon, and thank you for taking my questions, which are related to crisis staffing policies that allow COVID-positive healthcare workers to work in some situations. I'm wondering about what the definition of crisis staffing is. Is there a threshold for hospitals and other medical facilities? And is this a standard definition for all healthcare facilities in the state, or does it differ?
I can start there. Catherine, in general, and the way that the U.S. CDC has framed guidelines of that nature, it's up to the facility to determine when they have reached the point that they consider themselves to be in crisis mode.
Okay, thank you. And then, because I know that before they can implement that policy, they have to coordinate with the Maine CDC. So if a hospital approaches the agency and says they're at crisis staffing levels and they want to allow COVID positive employees to work, what's the process for approving or disapproving that policy?
Actually, there too, Catherine, the way that those guidelines are drafted, they are meant to be self-implementing by the facility. A facility need not get clearance, approval, or even notify the Maine CDC. The guidelines are completely packaged such that any facility can take them off the shelf, read them, and implement them for the situation that they're facing.
Okay, so can you just clarify then when St. Mary's implemented their policy earlier this week, they said that they were in compliance with the Maine CDC guidelines. So does that just mean that they alerted you to the fact that they were implementing it?
No, Commissioner?
No, I mean, just to be perfectly clear, there is no requirement in the US CDC guidance adopted by Maine CDC that there is a notification from the hospital or facility to Maine CDC or the state. We did not get notified by St. Mary's ahead of time. All that said, again, as Director Shah said, there's self-executing guidance that the US CDC put out in recognition of the fact that Maine is not alone in having its hospitals and healthcare facilities dealing with Omicron surges. So it put out that guidance in advance to ensure that the process was expedited.
Okay, thank you for clarifying that.
Mm-hmm. Thanks, Catherine. Over to Kevin Miller next.
Great. Thank you very much. Hi, Dr. Shah, Commissioner. Joe beat me to the question about what percentage of schools have universal masking, but following up on that, I imagine that the challenges of contact tracing are the same, whether a school requires masks or doesn't, and that the Omicron is going to outpace that contact tracing. regardless. So I guess, can you explain a little bit more about kind of the distinction between allowing schools with the universal masking requirement to not do contact tracing, but that still means the schools that don't require masks are going to have that challenge of doing the contact tracing?
They will, Kevin, and I acknowledge that. So, contact tracing, even though its effectiveness is reduced in the face of Omicron, it's not zero value. It's just reduced value, or reduced effectiveness. And so, if we are removing that, what can we put in place to ensure the continuity of in-classroom education? And that, for us, looking at the data around what works to keep kids in school is really, truly masking. You're right. There will be schools that do not have masking requirements in place, where we will recommend that they continue to do contact tracing. That will be in effect. That will help those schools that do not have masking in place at least mitigate some of the transmission that might be occurring because they don't have masking in place.
Okay, great. And another question, I'm not sure if it's for you or for the commissioner, but the states, there have been a couple instances now where the state medical licensing boards have sanctioned physicians for, or at least taken steps to sanction physicians and suspend licenses because of COVID misinformation. And the most recent one was yesterday. And I know that one of those lawmakers briefed lawmakers, or one of those doctors briefed lawmakers a few weeks ago. Can either of you talk just about what you're seeing as far as the extent of misinformation that's out there? Are you seeing things? Is it getting worse? Is it, getting better? And kind of how are you trying to address that?
Yeah, I guess I'll begin. I don't know that we have any good baseline to say, is it getting worse or is it getting better? I do think that the nature of the information and challenges with information have been with us since the start of the pandemic, about how quickly it spreads, do masks work, what are the types of therapeutics that work with COVID-19. So there's been certainly an evolution in the types of information and challenges with veracity of information throughout the pandemic. All that said, I feel as though we all have an obligation to look at the research, to look at the science, to make sure statements are checked and double checked. I know that Director Shah spends hours preparing for this particular briefing for that very reason. The importance of accurate and grounded information clearly matters a lot in this COVID-19 pandemic, if not in other areas of our public life. So we continue to appreciate the questions that we get from the public and the press about our sources, why we're making recommendations in a certain way, and we will continue to try to, when there is information that we don't think is accurate, counter it, and we do appreciate the media doing the same.
Great, thank you.
Thanks, Kevin. Patrick, last question goes to you.
Thank you very much. I just wanted to make sure that I understand some of the changes about contact tracing. So this sounds like the plan is essentially to back off contact tracing in schools that have a mask mandate?
They may back off. They may suspend contact tracing provided they have a mask mandate in place. I heard from one superintendent who wondered whether, even though they did have a mask requirement in place, whether they may continue with it. That's a call for each school, but these are really the conditions under which a school may suspend contact tracing.
I see. Also, and the thinking here, the thinking behind doing this is that you sort of use the analogy of trying to catch a bullet train with a bicycle. So the problems with the Omicron variant are that it spreads so fast and it spreads in the early part of infection, and that sort of has reduced the effectiveness of doing contact tracing itself.
That's right. Patrick, we have to take a look at, in addition to the challenge that it was posing for schools, in addition to the fact that it may have been keeping kids out of the classroom, we had a foundational question of, in light of Omicron, what is contact tracing doing? And what we found is that because Omicron spreads sooner, more aggressively, and more quickly after exposure. By the time that a school was able to locate a close contact, that child, if they were going to develop COVID, may have already done so. And so contact tracing at that juncture doesn't add much. We have to be real about that. We have to be very pragmatic about the steps that we're taking right now. When you build on top of that, how much COVID there is out there, the notion that if a child is not in school, at home, they're not at any risk for COVID doesn't quite add up. Kids, even if they're home, may be seeing their friends, they may be getting together. So we've got to be really pragmatic about what we're doing and making sure that it aligns with what we know about Omicron. Given the contagiousness, given how quickly that train moves, contact tracing in this day and age is not, it's difficult for it to keep up in school settings. In other settings, there's still value of contact tracing, for example, in nursing homes and places like that.
Question from a reader. Is there anything special that folks should look for regarding surgical masks to know that it's going to get the job done? And what specifically should they be looking for?
So recognizing the question that Allegra asked earlier about counterfeit and the veracity of what's being sold, holding that aside for a moment, the things you want to look for in a surgical mask are whether they are considered or say they are 3-ply. That is really the art of what a surgical mask is. It's multiple layers within the mask that are heat fused together that create the semi-impermeable or impermeable membrane boundary that prevents you from sucking in the droplets. So the thing to look at when you're looking for a surgical mask is to make sure it says that it is multi-ply or something of that nature. And oftentimes if a mask bills itself as a surgical mask, that's a shorthand for saying that that's what that mask provides.
Okay, terrific. Thank you very much.
Thanks, Patrick. And thanks to all of our colleagues in the media for their questions today. Commissioner, I'm happy to turn it back over to you to wrap us up.
Sure, thank you. And I would like to thank every member of the Maine National Guard who is being called into service to help fight this COVID-19 pandemic. As the governor said yesterday, she wishes she did not have to take this step. But the rise in hospitalizations is stretching the capacity of our healthcare system thin, which jeopardizes care for Maine people, as well as putting strain on our already exhausted healthcare workers. We promise that this is the last resort. We do this with caution. We will hopefully quickly be back to a point where people can go back to their full-time jobs, and our healthcare workers can also get back into the type of care that they are trained to provide. The key to that is still vaccination. As Director Shah said, 70% of the people in our hospitals today are not fully vaccinated. So if you really do want to thank your healthcare workers in your neighborhood, in your community, please get vaccinated. Thank you.
Thanks, Commissioner. And thank you all for taking some time out of your afternoon to join us today. Appreciate everyone tuning in. Hope everyone has a good remainder of their afternoon. We look forward to chatting with everyone next week. Until then, as always, please be kind and take care of one another. We'll see everyone soon.